Stroke is a focal neurological deficit, which is of no other origin but cardiovascular in origin.
Depression is the leading cause of disability. Depression on its own is a persistent feeling of sadness, a persistent feeling of hopelessness.
Hello viewers, welcome to this week's episode on Health Watch. I am Angela Mwenze. Not too long ago, colorectal cancer was a rare disease in rural Africa. However, over the last 30 years in West Africa, published evidence has shown decade by decade increase in the incidence of colorectal cancer, thereby accepting it as a recognized disease in native Africa. Well, nevertheless, we must acknowledge that the incidence is a fraction of what is obtained in developed countries like Europe and America. Let's look at Nigeria. According to a 2019 article titled Colorectal Cancer in Nigeria, Changing Trends and Clinical Phenotype, published in the Journal of Cancer Science and Therapy, it reported that in the 1960s, colorectal cancer was the 10th relatively frequent cancer in Nigeria for both male and female. Now, this simply means that in the 1960s, we had very low to no colorectal cancer cases in Nigeria. However, in 2018, the relative frequency of colorectal cancer had increased to 5.8% and had climbed to the fourth position of all cancer frequencies. Amongst men, it is the second most common cancer, with prostate cancer as the commonest and the third commonest cancer among women after breast and cervical cancer. On the program today, we will examine why we have this increase in colorectal cancer. Can it be prevented? Where does colorectal cancer occur? My guest on the program today is not a new face. He is Dr. Kenneth Onyejekwe. He is the Senior Registrar, General Surgery, University of Abuja Teaching Hospital. You're welcome to the program, sir.
Thank you.
It's good to have you back.
Thank you.
Thank you for coming. Now, don't forget, you can send in your questions, advert placement, or inquiry on how to sponsor this program to the contact showing on your screen. Thank you so much for coming once more. So the last time we had you here, we talked on prostate cancer. So it seemed to be, I'm just calling you back to talk about cancer. So today we're talking about colorectal cancer. In fact, I was telling somebody that I was coming to the studio and he said, what topic are you speaking? And I said, colorectal cancer. Said, what is that? Is that a part of the body? I said, oh, you don't even know there's anything like that. So the first thing I would like us to do is to know, what is colorectal cancer, or where is this colorectal cancer? Where does it occur in the body?
All right. Thank you very much.
Yep.
The colon and the rectum comprise the large intestines in the body.
Okay.
So when we eat our food from the mouth, the food gets to the stomach. From the stomach, digestion continues to the small intestine and then to the large intestine. So the colorectal region is the distal part of the gut. And it starts from the cecum
Okay.
to the ascending colon, the transverse and descending colon, sigmoid colon.
Okay, I think there's something showing on the screen on that.
So,
yeah. Okay.
down to the rectum. So that is the picture of the colon and the rectum. You see, in the middle of that picture are the small intestines.
Okay. Okay.
So the small intestines feed their effluents into the cecum, and it travels up the ascending colon, up to the hepatic flexure of the transverse colon, then gets down to the splenic flexure,
Okay.
descending colon, sigmoid and rectum.
Okay.
So this is the area that comprises the colorectal component.
Okay, the whole of that.
Yes, the colon and the rectum
Okay.
of the human digestive tract.
Okay.
So any cancer that occurs within this region is called colon or colorectal cancer.
Okay.
Yeah, so when about 50% of them occur within the distal colon and rectum, about 12% occur between the cecum and the ascending colon.
Okay.
Yeah.
So the cecum is where the final food from the small intestine gets into the
large intestine.
The large intestine. Okay.
Yes,
okay.
and that is the largest part of the large intestine.
Okay. Okay.
Yeah, the cecum. It's about 8.7 centimeter in diameter.
All right.
So from there, it gets to the hepatic flexure, the ascending colon. So about 12% of cancers occur there. And then the transverse colon has about 10%. Wow. And then the descending colon has 3% of cancers occurring there. But 50% of the cancers occur in the distal aspects, within the distal colon, sigmoid colon to the rectum.
Okay.
Yeah, so
all right, so on the other end
on the left. So we call it the left gut, the left part of the descending colon, and the right part of the colon. So the right part is the ascending colon, so the left part is the descending colon.
All right, okay.
Yes, but majority of the cancers occur at the distal region, the colon, between the sigmoid and the rectum.
Okay, okay,
yes.
Okay, that's what
so that is why we now call it colorectal cancers.
Okay, so definitely we know, we have learned before that cancers are unusual growth that occurs in, you know, any part. It can happen in any part of the body. But what I want to talk about first now is the statistics. So in the 60s, you would not really find the problem of cancer of the colon, you know, in this part of the world. But now, decade by decade, we're seeing it's rising gradually, and now it's becoming an issue. And the sad part is, it's even going towards the younger people. You know, before you would think it's maybe when you were in your 70s, then you'd be worried about cancer in the rectum and cancer in the colon. But now you're seeing 40. I know someone at 30 who had, you know, this kind of ailment. What's happening? Why are we having these issues now?
Yes, there are risk factors associated with the onset of colorectal cancers. And apart from the genetic and familial factors.
So if your family, if it's in your family, you...
Yes, about 80% of these cancers are sporadic.
Okay.
So they occur without a family history. But 20% occur in those who have family histories of cancers.
So when you talk about family history, does it have to be your closest family, or if you check somewhere, your cousin, really anybody can?
Family member, close relative, less than 55 years, you know, diagnosed for the first time, are all increased. The closer the relative, the higher the incidence and the chance of getting the cancer. So then the other factors like dietary factors, very important. We are having westernization of our diets. We're, you know, taking more of processed foods now, junk foods, you know, and these foods have less fiber in them. And so what happens is that there is a decrease in the transit time when food is ingested. There is no much fiber to aid the process of peristalsis. So the food content and food materials, both in any part of the colon, stays longer than it should stay.
Okay, let me understand, because you use the word now, peristalsis. That's the process of
peristalsis propels food.
Okay.
In a craniocaudal direction, from the top to the bottom.
Okay.
You know, it's a natural component or function ability of the gut.
And this is aided by fiber in the food.
Yes, it's aided by fiber in the food.
Okay.
Yeah. So when we take foods that are processed without vegetables, less bulk, less starch, you know, like we have in most of our local delicacies. So the transit time for food increases. That is, the speed at which food should move out of the body decreases. And so what happens is that the bacteria in the gut, you know, digests the bile salts. within the large intestine, converting them to some components, acids, the lithocolic and deoxycholic acids that cause irritation of the epithelial lining, the epithelium lining,
the top lining
of the colon, and so will induce some mutations within these cells, which can give rise to the cancers of the colon.
Okay.
Smoking,
let me talk on this dietary.
Yes.
So your food you eat is supposed to help us pass easily. So if you eat in the morning, it's expected that by evening you should have gotten rid of.
Exactly.
That's like a layman. By evening, you should have been able to pass out what is contained in that you have ingested. Your body has absorbed what it needs to absorb, the nutrient it needs. Now it wants to pass out.
Exactly.
Now, but if you don't pass it out well, then the bacteria in the rectum start working on
the bile salts.
Okay.
In the process of digestion, bile plays a very important role in the emulsification of fats, and it helps in the absorption of vitamins, the fat-soluble vitamins. So those bile salts also pass through to the large intestine.
So when we talk of fiber, I don't know, let me pull it out of you a little.
Yes.
Foods that we talk of fiber, I know I read today about beans contains a lot of fiber, which is a good one, which we don't even celebrate that much. And even some of our local food these days, like our rice, our especially the rice that contains, because nowadays you think you remove the
husk,
the husk and all that, and give us just what is remaining. But let's even take that one. But when you have other foods that don't contain fiber, then you're at the risk of keeping food longer within the guts. And so when it stays there, then it becomes a problem. Wow. Okay. Now that's very interesting.
Now again, the issue of westernized lifestyle, smoking, as I mentioned, smoking, the ingestion of alcohol, and then part of the junk food include the consumption of saturated fatty foods. Before, in the olden days, you perceive, when you enter villages, you perceive the production of coconut oil.
Yes.
Fish oil. All these things are protective. But these days we rush out with saturated fats. So all these are dangerous, induced changes within the cells. The epithelial lining. That's another thing. The epithelial lining of any part of the body are the most rapidly multiplying parts of the body, especially in the intestine. So as they are going through rapid multiplication through the cell cycle, we have the genes that control their replication, and then there could be mutation in those genes. There are genes whose function is to suppress tumors. We call them the tumor suppressor genes. P53 gene, APC gene, DCC genes in the colon, they suppress. So when there is a mutation, when all these things are present, these irritants are present, they mutate these tumor suppressor genes. And then it's no longer able to function to prevent the proliferation of abnormal cell lines.
All right. Okay.
There could also be activation of the oncogenes, that will help in the proliferation of cancer cells. So that's what happens in the colon. So part of the risk factors, all of them cause the same irritation. And with nice diets, smoking, alcohol. But there's something that is happening again when you compare the world today to the olden days. We also have to bring in the issue of international travel and international marriages. There are genes and precancerous conditions that could be acquired by this mixture, this marriage,
Okay, but I want to stay on that thought. I want us to go on a quick break. When we come back, we'll talk about this international travels that is beginning to, in fact, change our lives.
Yeah.
We'll be right back, viewers. On this show, we focus on the journey from girlhood to womanhood and everything in between.
You hear such comments like it's not ladylike because there is a way a lady should behave.
Please don't ask a man out. I beg you. We are so cultured that the day you do.
It is in that place of fellowship that you get to discover all these things.
You discover yourself.
Yes.
Biology-wise, women are able to progress faster into addiction than the men.
Don't crucify the woman for wanting financial security.
Remember, every woman is worthy by design. Welcome back, viewers. Before we went on the break, we were discussing colorectal cancer, and Dr. Kenneth is still with us. Thank you very much, sir.
Thank you.
So we're talking about the international travels that is beginning to, be part of the factors that is increasing cancer amongst us. Okay?
Yes, people, there are international marriages now. You know, in the olden days, there was nothing like the precancerous conditions that we have. There are certain syndromes and genetic abnormalities in the Western world that doesn't exist here.
Okay.
Okay, and then some of these children produced by international marriages can acquire some of these genetic defects.
Oh, right, okay.
And then develop these cancers.
Okay.
So that is the role of international travel.
Okay.
The advancement in science and technology has made sedentary lifestyle very common in this part of the world. People acquire, sit in the office and have everything without actually moving around. So
you can even shop online. You don't need to walk to the shops to go and get.
Again. So these are issues. People no longer go to farms to sweat it out. So it's insecurity has made people not to even exercise.
Yeah.
So these are all problems causing or giving rise to obesity, and all these are risk factors for the development of colorectal cancers.
Wow. It's amazing because one time I had a doctor on the program and he came to speak on hypertension, and he also said that in the 60s and the 50s there were really no case of hypertension, but over the years we're beginning to see these things happen. Now, how the symptoms, that is where because I really don't even know the symptoms of. What are the symptoms of?
Yeah, before the symptoms, it doesn't just occur like magic.
Okay.
It follows a sequence.
All right, okay.
Yeah, so when these cells get abnormal, the normal epithelium is injured by these irritants and poisons. It undergoes a dysplastic change, so it becomes abnormal.
So the epithelial cells on the
on that portion,
yeah,
it becomes abnormal, becomes dysplastic, and then it forms a little what we call an early adenoma. Later it becomes an intermediate adenoma, a late adenoma, which becomes a cancer. Okay, so we call it the adenoma carcinoma sequence.
Okay.
In colorectal cancers, and sometimes it can take about 5 to 10 years to occur.
All right.
Okay, yeah. So it's something that should be known.
Okay, so it's not a sudden. It doesn't happen.
It doesn't occur like an accident.
So let's say somebody is diagnosed with colorectal cancer at 40, which means he started damaging. Well, probably 10 or 5 years earlier, in his 30s, which is the age most of us are living carelessly.
Yes. So that is what happens. Okay. So the symptoms are related to the gastrointestinal tract.
Okay.
Initially, at the point of early onset of change of the dysplastic epithelium, those periods, the patient may be asymptomatic.
Okay, that's early stage, no symptoms.
You're not
seeing anything.
Then later, the patient could begin to have symptoms. And the disease varies on the location. The right side, the cecum, ascending colon, and splenic flexion, those diseases on that part, the symptoms are different from the symptoms on the left, the descending colon, and in the rectum. Okay, so in the ascending colon, the patient may come with altered bowel habit. Okay. Yeah, so I noticed that when you eat, quickly go to toilet, which there's a change in the pattern of emptying the bowels.
That's like diarrhea?
Yeah.
Okay. Well, it mimics diarrhea kind of.
It may mimic, but diarrhea has its own medical definition.
Okay.
But they want to talk about now the frequency of going to, so the patient may have generalized malaise, maybe weak, maybe losing, microscopically losing blood but not know. Okay, the patient may have later in the left side of the gut, usually present with obstructive symptoms.
Okay.
So the cancer in that portion. On the right side, mainly ulcerative. They cause a wound, which can deepen.
Okay, with time.
Yes, ulceration. We call it ulceration. Then on the left colon, usually come with obstructive symptoms. Okay, but for the tumor to grow around the circumference of the gut, of the colon on that side, it takes about 2 years.
Okay.
For you to have a completely stenosing circumferential tumor.
Okay.
So it travels about a quarter of the arc of the circle every 6 months. Okay, and then so they have features of intestinal obstruction.
All right.
Okay.
Okay.
So they somebody who goes to toilet every day may not go to toilet until once in 2, once in 3, once in 5 days, with some abdominal distension.
Okay.
And then intermittently the patient may be having some kind of spurious diarrhea, because of irritation, especially in the left colon. There'll be spasm and irritation of the colon. Okay, so the patient will have this deep, painful urge to pass through, but when he goes to the toilet, nothing comes out. Sometimes just mucus comes out.
Okay.
Okay, so sometimes again, this stool may be coming out as pellets. We call it pellet-like stool.
What do you mean pellet-like?
Coming like the stool of a goat. You know how
okay,
goats
yes, that's like in small seeds. Yes. Okay.
So that's what happens. Then in the rectum and distal colon, sigmoid, rectal area, there may be bleeding, frank bleeding.
Okay.
Yes, and when there's involvement or obstruction of the veins supplying from the inner cushions, yes, the patient may come down with hemorrhoids.
All right.
So you have some people who have hemorrhoids as a result of a cancer in the colon or in the rectum. Okay? So these are some of the features. Then the patient will also be having this borborygmy, audible intestinal noise in the stomach.
Yeah.
Brr, brr, So these are some of the features. And then in advanced cases, the patient will present with frank intestinal obstruction.
They don't go to toilet
They don't go to toilet at all.
Wow,
So
okay,
what
this is when, of course.
Yes, that's when they present as emergencies.
Okay.
With abdominal distension, splitting of diaphragm, they can't breathe well. Then some also perforate. Yes.
Perforate the walls of the
colon. The tumor erodes and perforates into the peritoneal cavity. So feces begins to contaminate the entire. So the patient has a peritonitis.
Wow.
Okay, as a result of the cancer.
Do you get stomach pains and
abdominal pain? Some people,
pain?
yes, you have abdominal pain, vague abdominal discomfort.
But how do you know abdominal pain? There's so many of them.
Yes.
You could have abdominal pain today, then after maybe a long time you don't. Is it
Yes.
frequent, or it will be coming in?
Yeah,
bits,
it depends on the location
Okay, of course.
of the tumor and the nature of the tumor, the size. The patient may feel a mass. For example, in the right colon, the patient may be feeling there's something growing in my right lower abdomen.
All right.
Okay, so all these things will begin to help to elucidate and help to know what is actually happening in the patient.
So the structure, it is when your feces can tell you a lot.
Yes.
Of your frequency of stooling.
Yes.
Either you're stooling more or you're
less.
stooling less can tell you that something is
It's
wrong.
wrong.
So whenever you notice you're not stooling frequently or
Yes.
enough, it's time to have a check.
Exactly.
You know. But now you talked about when there's ulceration of that could mimic ulcer, isn't it? Or somebody might be treating you for ulcer, or I don't know.
No, when you're talking about treating some people for peptic ulcer disease has its location.
Location, okay.
So usually in the
stomach wall,
the stomach and the duodenum.
Duodenum, yeah.
And the symptoms are completely different.
Different, okay.
The location is completely different.
Okay.
Yeah,
okay.
but before somebody we have that advanced disease that's ulcerating, bleeding, and may perforate, there are other features that will come in.
Okay, so at the early stage when everything is occurring, you're just living your life normally.
Yes.
You're most likely not going to have any symptoms.
Exactly.
You just, so are we supposed to start doing some kind of check at a stage in our lives? Or
That is the ideal thing. Actually, from 50 years, people should start having screening for colorectal cancer.
Yeah.
Yes. Even though we are seeing these cancers now, even in younger people. We've seen it in younger children.
Wow.
Yes. So, but adults should screen, should form it a habit to screen.
Okay, so now I read somewhere, in fact, there was a study I saw one day, and I have this science page that brings up studies quick, and it said that it is clear now that processed meat, so you're talking of your sausages, you're talking about bacon, that these food are clearly risk factors for colon cancer. Clearly, there is nobody is. So, what is it about meat now and the processed meat that is it that it stays longer in the gut wall, or what's going on? What's wrong with meat?
Yeah, meats, contain the red meat,
Yes, the red meat especially, yes.
Saturated fats.
Okay.
The chemicals used in processing them.
Of course.
The chemicals used in preserving them are not friendly to the intestinal epithelial lining.
Right.
So they participate in triggering off these reactions that can cause mutations in the genes of the epithelial cells.
Oh, wow.
So that is what happens.
They have this corned beef that coming from another country. It's laden with a lot of salt.
Yeah.
You have this fish that comes in this can, and I can imagine natural fish. It can't even stay 2 days outside of the fridge, or even in the fridge. Sometimes after a week it goes bad.
Yeah.
And then you're shipping in this fish from another country which would have traveled for months, and then it gets on the shelf and it expires in 3 years, and people still take it to consume. That is dangerous. That's dangerous.
Yes.
Corned beef has a lot of salt, and
it has been found to be dangerous.
Wow.
So that is why we should try to remain as natural as possible. Yes. Because whatever we ingest has consequences, especially when we become frequent on this diet. Yes.
It can be so amazing how these things are just so food related. Now let's look at this. You talked about the screening, or how somebody knows. Now you've gone to the doctor, you found out that you're not stooling, or you're stooling frequently than normal, and at a point you're not even stooling again, and the person presents the case. At what stage you say is late and there's nothing? Because I'm yet to hear anybody that said I had the colon cancer is general name, everybody calls it. I had colon cancer, and then most of the cases I've heard, people don't survive. I don't know if it's about the treatment or it's about just late presentation, or what exactly is it. But you would know, of course you would have known a lot of people that would have survived.
Yeah, the the thing about cancers in general is that Africans present very, very late at the advanced stage of the disease. And one thing with colon cancers is that colon cancers may occur at multiple sites.
Okay, so you can have one
in the sigmoid, you can have one in the ascending colon, you can have one in the descending colon. You know, we call them synchronous tumors.
So they can occur in different places at the same time?
Yes, they can even have synchronous metastasis to the liver.
Wow.
Okay, and after surgery and after treatment, you can have some, metachronous recurrence tumors. You know, so that's one thing with the colon cancers, their characteristics. You know, so the ideal thing in the presentation is a thorough history.
Okay.
The patient, the doctor pulls you through the history and then examines you and then sends you for investigations.
Okay.
Targeting to make a diagnosis in the colon.
Okay.
Yes.
So if somebody notices the symptom, is to go and see a doctor first. And then with your history, they can then send you.
Yes.
Okay.
Some people will just present with bleeding, bleeding when they go to the toilet. Some people may just present with vague abdominal discomfort. Some may present with altered bowel habits. Some will say, I'm feeling something growing on this part of my... Some will just present that they're hearing audible sounds in their abdomen. Okay?
Okay.
So these are all the symptoms. Some may present, and then in the process we find out that there are other issues, including weight loss, including severe anemia, okay, and other complications that come with it. Some people would have had an enlarged liver by the time they come because of metastasis to the liver. Okay, so these are all. So the diagnosis is hinged on history, physical examination, and investigation.
Yes. We'll go on a quick break, and when we return, we'll continue. We'll not talk about how to prevent, and I'll stop if it is possible. We'll be right back, viewers.
When one is horrible, it means that there is nothing that is objectively good and progressive that will come out of such individual.
If you have been convicted of an offense before and you have been pardoned, and anybody is trying to bring that up against you and calling you a convict, you have the power to sue that person for defamation.
Justice must not only be done, but it must be seen by all to have been manifestly done.
Every citizen has a right and every citizen has an obligation.
That a plea of ultra-virus acquit or convict is very different from the plea of pardon.
Trespass is that act that interferes with the peaceful...
No matter how minute,
no matter how minute.
Who comes to equity must come with clean hands.
Welcome back, viewers. Before we went on the break, we're discussing colorectal cancer, and Dr. Kenneth is still with us. Thank you so much, sir. I don't know how I feel about this colorectal cancer. I really don't know how I feel. I think my feeling is just scattered everywhere because it's not something that you can dictate early yourself, to start treatment, because in this part of the world, it's really difficult. But so how do you start preventing? I know, okay, let's talk treatment and treatment to prevention. Treatment should be your problem, not really ours. We don't have anything to do with the treatment, yeah?
Yeah, before treatment, investigations you have to go through to pinpoint the location where there's an abnormality in the colon. It includes the colonoscopy, colonographies, and the staging investigations like a CT scan.
Okay.
Okay, but initially we also do barium NMRs, that will help us to show a double contrast barium NMRs where contrast are injected into the colon, and X-rays are taken, and these X-rays will show us areas of filling defects.
Okay.
Yes, and show us that areas of luminal narrowing.
Okay.
Yes, areas of abnormalities within the within the colorectal region. So after that, we do a colonoscopy and biopsy. So the camera, the colonoscope is inserted into the anus,
like a camera,
and then it's able to take pictures of abnormal areas and then biopsy, just take tissues from such areas for histologic diagnosis. So when all that is done, staging is done. The staging helps to show the extent of the disease, whether it's stage, we have the TNM classification that helps us to classify the disease into stages 1 to 4.
Okay.
And we have also the Dukes classification, modified Dukes classification that helps us to classify the extent of the disease, whether it is still confined within the epithelium.
Okay.
Whether it has gone beyond the epithelium to the muscularis mucosa, the linings of the gut, up to the serosa, the outer lining, and then to the lymph nodes, and then to adjacent structures, and also to the other parts of the body. Because the spread of the cancer, of this colonic cancer, could be by lymphatics, It could spread through the lymphatic system. It could spread through the blood. It could spread through the contiguous adjacent structures. And it can spread into the peritoneum, transperitoneal spread.
Wow.
So you have people having masses in different parts of the abdomen.
So
in fact, some of them having wounds, ulcers on the umbilicus, they are spread to the skin of the abdomen, and you have very nasty...
Does it work like other cancers, like breast cancer? It's more prevalent in the Western part of the Western culture. Amongst the Caucasians is more prevalent, but ours seem to be more aggressive when it comes to the man, the African, the dark-skinned man. Is that the same thing with colon cancer? Is it more aggressive with us, or is just the same thing cut across board?
Well, it's the same thing cut across board, but the problem is picking them early.
Okay.
And you can never classify the characteristics or the behavior of a particular cancer.
Okay.
Because their behaviors and the rate of the rate at which they multiply, grow, and kill are dependent on various factors. So for those that are genetic factors who have familial problems, usually occur early, and usually more aggressive. Okay, so that is usually what happens in most of these cancers.
So if you're genetically, if it runs in your family, then
problem,
history.
Yes, usually they occur early. Usually they are more aggressive, But the problem is even early detection.
Early detection is still the thing.
Yes.
But it's not like of course it's not as much as, it's even getting more prevalent, because in men it is the second after prostate cancer, and then for women it's gone to third.
Yes, and globally it is the third.
Globally it is the third now, and it's getting so bad. So since you can't, it has to have gone that far. Do we start telling everybody go and do a colon, even early? Because I had a relation who died at 30, from this, kept on going from complication to complication. And that's why I'm yet to hear of someone who had colon cancer who survived. Is always probably because, as you said, it's presented late. So what do we do? Do we all have to go and check? Must we get to 50? Because I feel like going to check like tomorrow.
The best thing is for there to be very well planned screening strategies.
Okay.
Public health services, in our, healthcare system. I always say that we lost the president from kidney complications, and then there is no strategic plan to have, kidney transplant centers free of charge for Nigerians. There's no strategic framework, so, but that's an area that we need to look at, the ideal thing is to have screening, early screening.
Early screening.
Yes.
Like they're thinking about cervical screening, they're even chasing you to do that.
Yes, to do that.
If your lady see what you do, we should start screening for colon cancer.
Yes.
Because unfortunately, you can't tell everybody to stop eating or change. We're just changing our diet, and
Exactly.
you can't really force people. They will still eat, what they want to eat. And so prevention now. If we're looking at prevention, of course, you've said from the beginning, eating more fiber so that you can have free passage of food, which I think is very important because we are exchanging our are there other things we do? Of course, early screening is another.
Early screening, exercise.
Exercise, okay.
Quit smoking. Consumption of alcohol.
Those seem to occur everywhere.
Avoid sedentary lifestyle.
Okay.
Okay, avoid saturated fats. Okay, so these are some of the things that will help in curtailing then avoid processed foods. Eat fresh foods as much as possible.
Okay.
A lot of vegetables and fruits, okay, they contain a lot of carotenoids and that help to nourish the cells and protect them from getting the insults from these toxins. So that is what we should do.
Okay.
Yes, and people who are obese should watch their lifestyle intake and all that. So to keep alive, and then of course go to the hospital when you suspect an abnormality.
Okay.
Okay, like somebody who is 51 years now, presented to me and said, whenever he noticed that whenever he takes pepper soup, he passes blood in his stool. And I told him that it's like saying that when you get to a particular junction, your car will start dropping oil. But when you go beyond that junction, nothing happens.
Okay.
Okay? I said you need a colonoscopy.
Okay. So don't take blood in the urine, like in the feces. Likely.
Yes.
Likely.
But our people will tell you, no, it's when I take too much sugar, when I take too much Fanta. These are early warning signs. Okay, some people will have some vague abdominal pain, they'll take analgesics, and then after 3 days it comes back again, and they'll keep managing. I don't know what is paining me here. Well, it's not disturbing me, I can go to work. So the disease keeps advancing.
Yeah, everybody feels that it has knocked you down.
Yes,
Everyone must do something about it.
Exactly. So people, and then listen to, when you have hemorrhoids, you say, oh, there's hemorrhoid, I'm using Anusol, I'm doing Cisbate. And your doctor says, go and do a colonoscopy. Let us rule out a cancer of the colon. Quickly do that, so that you arrest the disease at an early stage. When you arrest the disease at an early stage, the tendency for cure, yes, is there.
Wow.
The survival and the prognosis is better than when you begin to have an advanced metastatic disease that has spread to different parts of the colon, different parts of the intestines, the peritoneal cavity, the liver. And the outcome is dismal.
So the cost of doing some of this colonoscopy, if you, I keep calling because women, they chase you every day, go and do a breast screen, go and do a cervical screening. In fact, they follow you up and they even pay you to come and do a cervical screening. But for how expensive is it to do just a check, a normal screening for colon cancer? Is it expensive, or is it something we should start thinking of what to do about the cost?
Well, it's not very expensive.
Okay.
Yes, it's not very expensive, but the cost depends on the center.
Okay.
Yeah, these are services that could be rendered in government hospitals, like teaching hospitals, and then even private radiological outfits.
Okay.
So it depends on the location, but it's something that is affordable.
Okay.
And then if you can buy a brand new car of 5 million, or you buy land of 10 million, I don't think spending some money on your health will even be a problem.
Or you spend a lot of money on drinking and smoking.
Exactly. So
and buying junk food.
Yeah, so that is what people should consider, irrespective of the cost. It is when you are alive that you enjoy some of these items you've procured for yourself. So people should make it a habit.
Yeah, you know, sometimes when it comes to healthcare, it's easy to say it's expensive.
Yes.
But it's easy for you to go and blow money one night drinking what is going to destroy you eventually at the end of the day.
So that is what happens.
Okay, so we should watch on that and look on that.
Yes.
Okay.
Because treatment of advanced disease, in fact, is prohibitive. It's not something somebody can do alone. And the toxics, you know, because surgery will give chemotherapies, sometimes neoadjuvant chemotherapies to shrink the tumors, and then operate on the patient to remove the tumor, and then continue chemotherapy again. You know, it's a terrible process associated with a lot of pain and complications, you know, so with dismal prognosis, even when the patient's quality of life is not nothing to write home about. So people should be, the target is to nip this disease on the bud as early as possible.
Okay, so your advice now, if you're 50, watch your lifestyle generally from whatever age, 40. Okay, you can go for a screening.
In fact, if possible, from adolescence, because what we eat these days, what you consume, because I don't see why a young boy should be, because he has gained admission to the higher institution, should be smoking.
Exactly.
I don't see why he should be taking alcohol. I don't see why, you know, some of this carelessness starts from when people were very young, and then it damages their lives much later. So people should be careful.
Careful and
take
responsibility for your health.
Exactly.
Yes, your health is not in the hands of a doctor.
Yes.
It's actually you first. Then the doctor comes in when things just a little bit not right.
Yes. So that is it.
I think somehow this end part has put me in order, so I now know it's our responsibility. So there are things you can do to prevent. There are things you can do if you know the symptoms are clear. You know, you've already told us the symptoms to look out for, but the feces tells a lot. The feeling in the abdominal tells a lot of what is going on. If you notice anything and sometimes when something is going wrong, you know, I don't know what it is, but you kind of know that something is not right about my body. If you're not sure, it's good to go and see a doctor, and they might help you out on what the issue may be. Thank you very much, Dr. Kenneth, for coming on the program. I'm so happy you came and explained. I think my mood is okay. I think my mood is a lot better now. Thank you so much for coming on the program. It's good to have you. Good that you came. And for the past couple of minutes, I've been speaking to Dr. Kenneth Onyejekwe, the Senior Registrar Surgery at the Gwagwalada Teaching Hospital. Thank you, sir. Thank you for joining me on the program. For the past episodes on the program, we have invited different professionals in the medical field to discuss different types of cancers, from breast cancer to cervical to prostate, and now colorectal cancer. Most, if not all, of these cancers will be classed under non-communicable diseases, although it is still not very clear what is responsible for most of the cancers we have talked about. We know that there are risk factors that predisposes one to these cancers. The one risk factor that we hear all the time is change in our dietary pattern. Most of the broad adverse changes in dietary patterns include: 1, decrease in stable food rich in starch and dietary fiber, and we have increased in food from animal origin rich in total fat and saturated fatty acids. Number 2, we have reduced our plant protein sources of food, such as legumes, and increased our consumption of energy-dense snack foods, carbonated sweetened beverages, commercially available alcoholic beverages, as well as added sugar, fat, and oil in preparation of our food. This change in dietary pattern has also been accompanied by decreased physical activity, which leads to increase in overweight and obesity. Over the past 30 years, the mean body mass index, that's the BMI, has been steadily increasing even in low and middle income countries, including those in West Africa. It is mind-boggling the amount of fast food we are consuming, accompanied with soft drinks and alcohol, on a daily basis in a country or region that doesn't have the best medical care. We call it urbanization. Sometimes it is regarded as symbol of societal status, but I call it ignorance. I think it is time for us to return to our local delicacies. Our okra soup, our maize, our yam pounded or boiled, our plantain, our vegetables, the greens, the orange color vegetables, the red colored vegetables, our fruits, especially those that are grown locally, our local palm drinks, our roasted or green beef to replace processed beef, our family life of gist and laughing, playing in the evenings, and just loving one another. I believe that our local way of life is better than the foreign culture we are trying to adopt, and this is strictly with regards to our dietary pattern. It is time for us to take responsibility for our health. Thank you for watching. I am Angela Mweze. God bless you.